Ladies, do you know what to do if you think you might have breast cancer? I'm going to find out from a cancer doctor and an insurance advisor today what the process is like. So this is one episode you don't want to be missing. I'm your host, Polin. Welcome to TAW Real Chats, where life's insights are shared. Now with me today are Dr. Cheah Keat, an oncologist and radiologist, and Ryan Lim, insurance advisor from Allianz. We're all here as part of the campaign Her Time Matters, brought to you by Roche, because women, while you're busy taking care of everyone else's needs, you need to know that your time matters. Now, let's get right to the core of it. As a woman, we sometimes don't make time for annual breast screening, etc. Dr. Cheah, with breast screening, what should we be doing? I hear a lot about mammogram and ultrasound. What is right to do for the woman?
Yeah, thanks for having me here, Polin, on this platform. So it really depends on the age of the patient and of course risk factors involved. If you have a family history of a patient, a family member who has an earlier diagnosis of breast cancer, even when she's just 40 years old, you may even want to do screening much earlier than that. So various guidelines, but generally when you reach about 40 years old or above, or 45 in some guidelines, you want to consider performing the initial imaging, which is by using an ultrasound or a mammogram. But dependent on the breast density, some of the younger patients may have difficulty to be visualized and imaged optimally by using a mammogram. So we tend to use ultrasound for younger patients or with very dense breasts. That's really a very good initial diagnostic screening method. And we would like to see whether we can identify high-risk features. So there are various staging methods and classification methods where we can see whether this belongs to high-risk breast lesion, for example. Yeah. Sometimes you cannot really see it very well. You may need to do something like even an MRI, but basically the simplest test is necessary as a form of screening.
I see. Ryan, I have a question for you. So Dr. Cheah talked about ultrasound and mammogram. Are these covered by insurance?
Okay, so when we talk about medical insurance, it is mainly for medical treatment. So most of the screening for investigation purpose is not claimable unless this is followed by some medical treatment, for example, for daycare surgery, some admission treatment. So the screening fees can be claimable as a pre-admission benefit. Yeah, right. So this is some of the benefits in the medical card that can be vary from the company, from 60 days to 90 days coverage.
Okay, I'll pause you there for a little while. So does this mean that if, say, I want to do a mammogram, let's say I go and do a mammogram, you're telling me that I can't claim it. But if the mammogram shows a lump and I go off to see a breast surgeon to take out that lump or some sort of lumpectomy, then I can actually claim that?
Yes. So as long as it's within 60 days to 90 days before the surgery done, all the consultation fees, all the take-home drugs, all the screening fees is claimable.
Right. When we talk about mammogram ultrasound, that's annual screening. But in what instances would a woman, what are the symptoms where a woman really should just go and get a scan right away?
There are about some of the telltale signs, or we call it the red flare-up signs, where you should go and see your doctor immediately. And most of these patients who come to me with just a few days of symptoms or a week of symptoms come with mainly breast lumps, whether it's painless or painful. You can have any alterations on the skin color. You may have puckering, changes in the symmetrical shape of the breast compared with the contralateral breast. And also even sometimes, if they have persistent discharges, especially with blood-stained discharge, they should seek medical attention immediately. So in fact, I recently had a patient who came in. He's got a lesion on the chest wall. There's no lump, right? But he just remarked to her close friend that it's really out of shape. There's a bit of a puckering, looks a bit different from usual. Right. But the friend, who is really quite an enlightened person, quickly pointed to her that it might be something which is growing, which is pulling it inside. and immediately seek medical attention. And we did some scans and we found out there's actually a lump on the chest.
I see, I see. So those are the symptoms that we really have to watch out, and then women should quickly get a scan done. So in that case of your patient, right, where they've got a scan and you found a lump, what should be the next step for the woman?
Yeah. So the standard option, of course, is to perform a true cut biopsy. The core biopsy or true cut biopsy is really a very safe method. Most of the time, we do it even on a daycare basis where they just have to be admitted to the hospital for about 6 hours. They can be discharged. For example, if you were to do the procedure in the early morning, for example, let's say 10 a.m., they can go back maybe after about 6 hours of monitoring in the daycare and they can go home and be with their family. And they usually have very minimal complication rates because it's just a very small needle, and the surgeon or the interventional radiologist usually will be able to monitor for any bleeding or any other problems immediately after the procedure. So the risk of infection, the risk of wound, for example, with larger kind of wide excision is really minimized, and you're able to even start treatment in as soon as possible once the results of the biopsy or the hormonal studies are made available. And so we oncologists who deal with breast cancer on a day in, day out basis have various ways to treat these patients pre-operatively, so that we can achieve a better outcome. So there are various subtypes of breast cancer. For example, triple negative, a triple positive, or even a HER2 positive disease. So these diseases are no longer treated with surgery first.
I see.
And various studies have actually shown that if you were to treat them initially, and I can share with you some experiences where even a patient who had the whole breast, which is full of tumor and is inflamed, it's difficult for the surgeon to clear everything in one go, no matter how expert and how capable they are, because of the biology of the tumor. So ideally, some of those extremely large tumors, and you may want to consider breast conserving approaches and techniques, which is also, of course, better for the patient's psyche as well as impact of the control as well.
Allow me to just pause you there because we've got a lot of medical jargon happening. What is breast conserving surgery? Could you explain to our audience?
So breast conserving techniques are essentially breast surgery, which is not removing the whole breast. Okay. So in simple terms, you have a mastectomy, which is removal of the whole breast tissue, and there are various types of mastectomies involved as well. But generally, we do not want to do such extensive surgery, sometimes for the lesion which is just 1 centimeter in size.
Right.
All right. So can you achieve that if, let's say, the patient has a tumor which is measuring 5 centimeters, 6 centimeters? It may be quite difficult, especially in the Asian population, right? So that's when some of the treatment which are being used to treat before an operation, we call it a neoadjuvant approach or pre-operative approach.
Right. So what is this neoadjuvant approach? When you say don't do surgery yet, what do you do then?
Well, depends on the subtype. We sometimes use hormones, we sometimes use chemo, antibodies. These treatments, well, they're not just shrinking the tumor so they can do better surgery, maybe breast conserving surgery, or even to be able to do a curative surgery. For example, you have huge, the whole breast is involved. Sometimes you can't cure them if you don't do this kind of treatment. But at the same time, you'll be able to assess response in vivo, meaning that you are going to see the response in that particular patient, and you'll be able to assess whether she will have a better outcome. For example, if you have a complete pathological response with the systemic therapies that I've just mentioned, you may actually have a better outcome. Because I can tell you the patient I saw maybe a couple of months ago who had a tumor infiltrating the whole breast. She actually had a complete pathological response after treatment, and she subsequently had surgery done. So this is what we are talking about. If you want to treat this patient in the best optimal manner, some of approaches incorporating new adjuvant treatment is going to be more effective than going for surgery, which is sometimes inadequate to clear the tumor, and you potentially having a lot of issues treating them after surgery.
Right, right. So from what I hear from you, so if a woman has a lump, right? We've done the scan. There's a lump, so we will probably do biopsies first.
That's right.
Right. And I think you mentioned that it doesn't have to be a cut biopsy. I suppose these days we have core needle biopsy, isn't it?
Yeah.
And assuming that the core needle biopsy shows cancer, then you're saying that there could be a neoadjuvant approach whereby the woman receives different therapies, could be hormonal or could be chemotherapy to sort of shrink the cancer or in a more curative way before surgery. Did I get you
Yes.
right, Dr. Cheah?
That's accurate.
Thank you for that, Dr. Cheah. Ryan, I need to come to you because there's so much that Dr. Cheah was saying about, right?
Yes.
We're talking about biopsies, core needle biopsy, true cut biopsy versus a surgical approach. And then he went on to talk about different treatments first before surgery. Ryan, are all this claimable from insurance?
Okay, so for biopsy, it's still in the investigation process. So it's not claimable until we go for treatment, either it's by surgery or by some other new treatment like what doctor mentioned, hormonal therapy, immunotherapy, even targeted therapy are covered in the latest policy, medical policy in the market. But for the older version of medical plan may not be in their list because previously, if your policy are very old, like 4 years and 5 years ago, you never go and upgrade it, your policy may just cover for surgery, chemotherapy, and radiotherapy. So when it comes to new treatment, it's not claimable.
Right. Talking about new treatment, Dr. Cheah, are there many new treatments in breast cancer?
Well, the research into cancer treatment is really exploding at the moment. We have a lot of new treatment options, not just chemotherapy alone. Of course, chemotherapy is an important aspect of treatment, but you have multiple targeted therapies, antibodies targeting the HER2 receptors, and you also have something called the antibody drug conjugate. So the list goes on and on. Wow. And sometimes because the medical research and also it's really exciting that the other industries, especially the insurers, probably need to be aligned with the developments in cancer treatment. That means we should be engaging them more frequently and have an open dialogue between all the stakeholders.
So if I'm hearing both Ryan and Dr. Cheah, right, the older policies may not cover the newer treatments for breast cancer that has been proven to help women with breast cancer, right?
Yes.
That's what you guys are saying. Now, so if I were to be buying an insurance policy, I need to be looking at whether my policy covers these treatments. That's what I'm hearing. But what about the limits? Because with insurance policies, there are usually limits. Are these treatments more expensive, these newer treatments, or are they about the same as previously? What sort of limit do you, in your practice, Dr. Cheah, would you be looking as reasonable that a woman should consider?
Yeah, so we now hear that there's so many policies now covering up to the millions range, maybe 1 million, 2 million range. That is really fairly adequate amount to cover a lot of treatment options.
Wow.
For the majority of cases, I must say that the treatment may cost in a region of a few, maybe tens of thousands, maybe for very simplistic treatment of just adjuvant chemotherapy, radiotherapy alone. But if they were diagnosed with certain forms of subtypes, such as anti-HER2 therapy, requiring anti-HER2 therapy, then the treatment cost may escalate to the region of about hundreds of thousands. All right. So in cases like this, probably if you really want to give a limit, which amount is adequate to cover for some of the newer targets, I would say maybe 400, 500,000 minimum if you want to be very assured. that's going to cover. But most of the newer policies that my patients are using currently
Right.
does cover up to that range, even up to 1 million. So I when we treat these patients, we also feel assured that we can give them the best that medical therapy has at that moment.
That's really astounding, because that means that if my coverage doesn't have those sort of limits, you're saying that I might not be able to access these breast cancer treatments, because you're talking about millions and hundreds of thousands. I mean, they scary numbers. It's like life savings, some of us don't even save enough that sort of money in our lifetime. And so Ryan, how what sort of premiums are we looking at per month if you're looking at that sort of coverage?
Okay, so let me share my experience of one of my clients. She actually go through some breast cancer treatment, a combination of immunotherapy and also chemotherapy. So her bill is around 300,000 plus. So there's a good news, because she had actually upgraded her policy before she diagnosed with the breast cancer to at least 1.5 million per year annual limit. So she managed to get the best like treatment and technology to actually help her to go through the crisis. Yeah. So for this case, the insurance premium is actually very depending on the age when we apply for the insurance. The younger we apply the insurance, the healthier our body, our premium is lower. So that means when we are try to apply the insurance at our 40s, it's definitely will be more expensive than the 20s.
Right. So actually, women should be looking at getting their insurance really early on in the 20s. That's what you're saying, Ryan.
Yeah. When we are still young and healthy.
Right. Now, I understand that when we speak about newer treatments, there are newer treatments where they are administered by subcutaneously, Dr. Cheah. I mean, that's a big word. Can you explain what subcutaneous application of medicine is?
Well, there are various methods of delivering, for example, hormonal treatments and even antibodies. These are deliveries which are meant to simplify delivery and also minimize your staff and also your daycare usage as well. Because in the past, there are medications which are given over, for example, 2 to 3 hours. Right. And some of these medications, they managed to develop a formulation to be given just by an injection into the anterior part of the thigh. There are injections given to the muscle, but there are specific injections which are given under the skin. So you do not need to have a granula. You do not need to have an infusion. You don't have to sit in the daycare for hours and hours. So that will free up a space, and that will also allow the patient who goes for the subcutaneous injection to have the treatment very conveniently within a few minutes, very little waiting time.
Wow.
And that even may allow the delivery to be done at home. For example, if you do go for ambulatory services, although ambulatory services have not developed to a high level and in cancer care in Malaysia, but evidently it has been adopted in some countries in Europe, in UK, even in Singapore. I hear them that they are actually going to the community, making delivery or treatment more accessible and easier, and in fact cutting down on some of the costs involved as well. So I believe in the long term, if we have the numbers, we have the logistics, we can develop all these, the patient will benefit from them. The cost may come down, especially they are not required to come into the hospital. We may cut down on the incidentals, and as well as maybe less blood taking and so less time on the road.
Wow. No wonder you said breast cancer treatment is very exciting, because first, you said, the patient may, for some treatments, the patient doesn't have to sit in the daycare for hours anymore. They could just take a subcutaneous injection of a few minutes. And then you spoke about what the future is like, doing it at home. You don't even have to go to the hospital. And I think it'll be so meaningful for the patients when it's such a tiring process when they're going through some of these treatments.
Yeah.
But Ryan, where is
Yes.
insurance with all of that, given Dr. Cheah just described the future? Are these options actually covered by insurance?
Okay. So for insurance, we doesn't really matter how it's actually inject through IV or subcutaneous, as long as the term meet our criteria in the policy, which is the outpatient for cancer therapy. So including the chemotherapy, radiotherapy, immunotherapy, targeted therapy, and hormonal therapy. Basically, we will actually approve for the coverage.
Oh, wow. Okay. So that is covered. So that's good news. What about home care? When I know home care is a big deal now. Cancer treatment being given at home in countries like Dr. Cheah mentioned in the UK, in Singapore, but in Malaysia it's a bit behind. But does that cover it?
Okay, actually, home care trend just started to be more common during MCO because people worry about the virus, not there to go to hospital. So during that time, we more and more hospital actually try to promote their home care services. So for now, for insurance, some of the big insurance company already start covering for home care services, like including COVID treatment, dengue, cellulitis, even some of the cancer treatment, if they are allowed to taking the medicine at home by themselves.
Right. So there are inroads going in with some of these things. Now, just one more thing I want to ask you, Ryan. You've been talking about medical plan as we talked about what's claimable and what's not. I also hear the term critical illness being thrown around. Is it the same thing or is it actually a different thing?
Okay, when we talk about medical plan, is the medical card that we usually talk about. So medical card only cover the medical cost when we admit to hospital. So it do not cover the medical expenses like after we discharge from hospital. So a lot of people neglected this thing because the time that we stay in hospital is actually shorter than the time that we stay at home for recovery. So when we discharge from hospital, we actually need some time to rest at home, to recover before we get back to work. So let's say we are diagnosed with a serious illness like breast cancer or even kidney failure. So we may need to take a break and stop working. So our main source of income will be stopped. So this critical illness coverage is actually a sum of cash money. It will be paid up when we are diagnosed with critical illness. So when we get the money, we can actually use the money to cover our living expenses. Even we stop working, our income are stopped. And even we can use this for like get a better food, organic food, supplements, and so on. So this is the function of critical illness.
I see. So what you're saying is there's the medical plan, which is the medical card, and then you got critical illness to help with the living expenses, and woman needs to look at both of them to juggle it up.
Yes, correct.
What about the actually claiming? Let's go back then in that case to the medical plan. Dr. Cheah, what do you think are some of the hurdles for women in trying to claim insurance? Is it like a really straightforward experience, or is there a sort of a tussle?
Well, it depends sometimes, especially if they just bought the plan maybe a month, 3 months, or 6 months before. The insurers might want to
investigate.
They might want to make sure that is this a genuine claim. So we doctors, of course, will just go on the book because they tend to come to us when they just felt the lump just a week. But sometimes genuine cases where they just bought the plan maybe 6 months ago or 1 year ago. So they might come to a situation where they may not allow them to go ahead with the claims yet until they are cleared by the medical team involved. So, but for the rest of the patients, usually I do not have much problems because it's a very straightforward thing. Once they're diagnosed with cancer, for example, through a biopsy, it's a very clear-cut black and white report. Most of the patients do get their claims without much problem. So even, for example, we are talking about biopsies. We sometimes when we detected a lump, we feel that this is a BIRATS 4, very high risk for malignancy change. We sometimes even submit a request to the insurers to admit the patient under daycare, and some of them do get through, so it's really beneficial to them because they struggled with the cost of treatment and even the investigation part, because investigation also will cost them easily a few thousand ringgit. So even that part, we sometimes help them to submit a GL, a guarantee letter for them to be admitted under the cashless system. Then subsequently, we are talking about the medical claims. We frequently fill up forms. So whenever I see a critical illness claim coming in, I know this is to help them to buy better food, to have maybe to buy
organic, as Ryan said.
To spend some not some of the claims for the children's education, etc. Because they're maybe off work, they may not be able to continue. So those are really very important claims that I sometimes try to fill it up for them as soon as possible so that they can get it done. So those are different because those are for the critical illness. Then for each and every treatment, we actually have to submit insurance GL for them to have. So each and every cycle of the chemotherapy, immunotherapy, even injections for hormones sometimes, and subcutaneous injection, we usually submit them either a few days earlier or a week or two earlier for the insurances so that they prepare and they can get the treatment without any delays. Because it's a 2-weekly, 3-weekly kind of regime. So it's a very clear regimen that we are offering to the patient.
That's very insightful. Ryan, when the woman has all this and how do we get the process started for the doctor to claim? Do we actually contact our insurance agent or do we just liaise directly with the doctor?
Okay, so basically if the client already go and consult a doctor, so doctor will actually have a insurance team in hospital. They will actually help assist client to go to apply for the guarantee letter, the GL that doctor mentioned. Yeah, so actually the job of an insurance agent is to make sure the process go faster and smoother, because sometimes there might be a delay in email the document from hospital to insurance company, or the delay in insurance company to process the document and give the approval to the hospital to do the procedure. So our job is to follow up and fasten the process to make sure everything done so that client can actually have a peace of mind to go for their treatment as fast as possible.
Right. So with this guaranteed letter, that means that the patient's not out of pocket. Is that right?
Yeah. Once we get the
cashless.
guarantee letter, we don't need to pay anything. Then insurance company will actually deal with hospital to settle the insurance bill, the treatment bills.
Right. One other thing that I wanted to ask, based on what the both of you were saying, should the woman actually buy the insurance first or go screening first?
Okay.
Which of you would like to take that question?
I think I let the insurance answer the question first.
By me first. Okay. So normally, if let's say a client come to me and say, Ryan, I feel something wrong at my breast. Whether I want to go for insurance first or go for screening first. So at this point of time, normally I will advise them to go for screening because they already feel something wrong in their body, and definitely they will go for like some GP for screening or what. So once we have record in clinic, so definitely insurance company will be able to trace it. And for their own good, I will advise them to go for screening first before apply for insurance. Because once upon we apply for insurance, we have to declare our health condition. So either we receive a proper consultation from doctor or not, or we already realize something wrong with our body, we have to declare, or else, like what Dr. Cheah said now, a very new policy, if they suddenly, upon approval of the insurance, they go to see doctor for screening and found out something wrong, then the insurance will be get on hold for investigation purpose until the company feel is clear, only we will approve for the insurance claim, or else the claim will be declined. And the whole medical claim will be on hold for any type of treatment because we suspect non-disclosure.
Right. So what you're saying is if the woman feels something wrong with her breast, she should go for screening first. Otherwise, it may cancel out her whole insurance plan. But assuming she does that, I'm assuming that the insurance will then exclude the breast from being covered, right?
Yeah. So don't be upset if insurance company offer you an exclusion, because I do have a successful cases. My client was diagnosed with a cyst in the breast. When she applied for the insurance, she get excluded to cover the breast. But after that, she went to remove the cyst from the breast. Then after 2 years with no relapse, we actually appeal for her and she get full coverage now, including the breast. Yeah. Wow. So that is a way to do. So consult your insurance agent when you feel you need their advice after you meet doctors.
So ladies, you're listening in. I think the wisdom here is that you should be buying your insurance when you have nothing wrong. Way ahead before you feel something wrong with your breast. Would the both of you agree?
Yes, definitely.
Well, Dr. Cheah, before we finish, would you have any last words of advice to women about breast cancer, about their breast, or about insurance?
Well, do early screening because early treatment, of course, will lead to a successful and better outcome. Prevention, of course, is the best method. But we don't really know how to prevent cancer in most situations. So the best to us is, of course, early screening, because it really can be the difference between a cure or non-cure, especially if it is in advanced setting. Then it makes the treatment more difficult for the doctors, and it's more costly as well. So, and in terms of the insurance, of course, what you said is right. I echo that you should be having a good coverage, because it's really a bit more of a financial planning. So don't buy insurance when you're already sick, because you can't get any insurance at that time, right? So get it when you're younger, probably, because then you'll be getting it at a much better kind of premium, I guess.
Yes, correct.
Ryan, anything else that you'd like to add before we wrap for the time?
Well, get your insurance agents to do a review for your insurance policy, like at least every 2 years, or when you have big changes in your life stage, like when you get married, when you have more child, or you will get a big loan for house or car. So to make sure your coverage is up to date, enough for you to go through the life crisis when we are attacked by a serious illness.
Right. So from what we are hearing today, get your insurance while you're still healthy. Don't wait to be sick before you do it. And if there was really something in your breast, there could be steps and means to actually address the situation and still have the breast covered by insurance, right? And from what you're saying, early screening is the way to go. So much insight from the both of you today. I cannot thank you enough for joining us and sharing your experiences. Thank you so much, Dr. Cheah and Ryan.
Thank you.
Everyone, give us a thumbs up, hit that subscribe button, and we'll see you at our next Real Chats episode. Bye for now.
Bye.
Bye-bye.